So let's see. Dr. Horlyck-Romanovsky is an assistant professor at Brooklyn College, and she's committed to addressing intra-ethnic health inequities among immigrants and minority populations. Her New York City-focused research examines intra-ethnic obesity and diabetes risks and compares the health profiles of African Americans, African-born Blacks, and Afro-Caribbeans. So thank you so much for joining us today. And I give the seat to you.
Thank you. Thank you so much for the opportunity. Can I share? Yes, I can. So let's see if we can get this to, there we go. So thank you for the invitation to speak today. I'm really thrilled. And when Nozomi reached out to me a couple weeks ago, or a few weeks ago, I said, so what do you want me to talk about? And this is what she wrote to me. And so I've tried to let that guide me and be as broad in my research rather than sort of drilling into one aspect. I'm going to be pretty broad and give you some cameos about some of the research. And I wanted to make it relevant both to Brooklyn and to you. And it's good to know a little bit about the breadth of expertise that's in the group. So, so you may ask how this work started, right? And because we are often identified by how we, as researchers, how we relate to the research. And you've seen me, I don't look like I'm Afro-Caribbean or African-American, I'm not. But I'm a public health practitioner. I've been that for a long time, but I went back to graduate school kind of in reverse. So I worked for a number of years and then I went back because there were some questions I couldn't figure out how to answer in health inequities, in food access, and in some systemic issues that sort of predicted how health outcomes manifest early on in life. And I knew I worked on teaching nutrition education to kindergartners and first and second graders and running programs, but I knew that teaching those kids to cook would not really change the underlying conditions that they were experiencing. But just like physicians have to take the patients that present in their practice or in the clinic at the hospital, and the nurses have to address the needs of the patients in front of them. In public health, we have the same task, that we have to take the public health issues that present themselves in front of us. And so I was teaching at Brooklyn College for several years while I was in my doctoral program, and I would send my students out to do community assessments. Go talk to people in the streets, go look up the data about particular communities and find out what concerns people. And the groups I sent to Central Brooklyn and to the Flatbush communities consistently came back with the concerns of the community, in the Afro-Caribbean community in particular, are high rates of hypertension and high rates of diabetes. And so I asked them to go look at the literature, and they came back from the library and said there is nothing in the literature about the Afro-Caribbean community and chronic disease in the United States. And at first I didn't believe them, but then we looked together and lo and behold, we found that there was a dearth of evidence on what is actually experienced by this community. And then we broadened it to look at all populations of African descent, because, as you will see, it became obvious that heterogeneity of risk really was apparent, and it became more and more complex as we moved into it. So tonight I'm going to talk about, first, just quickly look at obesity and type 2 diabetes prevalence. You've probably heard about this ad nauseum. And then I'm going to talk about heterogeneity in terms of BMI and age. And then I'm going to talk a little bit about other clinical criteria. I'm going to talk about challenges in diagnostic criteria, and specifically just refer briefly to my work on the performance of hemoglobin A1C. And then I'm going to talk a little bit about a dietary assessment project that we did in the Jamaican community. And then I'll talk about the implications and what we can do together as healthcare providers and researchers. And I love questions, and I'd love your input on the in the debate. So the assumptions in the United States are that people of African descent are at higher risk of obesity, a higher risk of type 2 diabetes, and that obesity is one of the primary drivers of type 2 diabetes risk. And that's also perhaps true if we look at it on a national scale. And then in the narrative around COVID-19, morbidity and mortality has really further deepened this judgment and prejudice of the health of minorities in general and African descent populations specifically. And we know that COVID-19 has disproportionately affected Black New Yorkers, so much so that both in New York City and nationally, people of African descent were more than twice as likely to be hospitalized than whites if they did develop COVID-19. And then that underlying conditions such as heart disease, type 2 diabetes affected about 85% of the COVID-19 deaths. We also know that mortality rates were twice as high for Black New Yorkers compared to white New Yorkers. And we can speculate that this is possibly due to Blacks being disproportionately affected but by type 2 diabetes, but also because the Black population in New York City faced the triple or quadruple burden of health inequities, higher risk of chronic illness, and then also higher risk of COVID-19 exposure and mortality. But we also have to remember that race doesn't define risk, and disregarding heterogeneity of a population who happens to share skin color characteristics really obscures important cultural, genetic, and phenotypic differences. And so I just want to remind everyone that race is a social and political construct that doesn't have inherent genetic or biological basis. The concept really is used to justify issues of exploitation and violence, and it racializes our research, even when we begin by the first characteristic by which we sort people is skin color. And so we're not going to talk about race per se, but I'm going to talk about it within the context of this classification, that we sort of need to flip the lens and look at race possibly as a contributor, but not the first measure by which we sort people. So today I'm going to show you multiple forms of heterogeneity as they relate to type 2 diabetes alone. So we, in New York City, just to get a sense of magnitude, in New York City, the population is made up of still the dominant group is whites, about 43%, but about 25% of the city is actually Black. And so this is a sizable population that we need to really understand more about, and similar to how we have begun to disaggregate Asian research, we also need to look at the African descent peoples and look at diversity within that. And that's because in New York City, we also know that we have an extraordinarily diverse Black population. About a third of the Black population are immigrants. The smallest fraction are Africans. About 600,000 are Caribbean, but it's estimated, and those are people who were born in the Caribbean, but it's estimated that 50% or more of the New York City Black population actually has recent Caribbean ancestry. Now we have to remember that much of the peoples who were enslaved during the times of slavery all came through the Caribbean. So there is sort of ancient or old admixture from the Caribbean, and there's more recent Caribbean arrival. And why talk about Brooklyn? Well, one, you're here. Two, Brooklyn College is here. So depending on our lens, Brooklyn is really the epicenter of who we are as institutions. And then again, my patient, my public health population that presented itself to me was really the red and dark red areas that you can see. This is actually a map of from the Census Bureau, but it's actually a map that has to do with voting and districting. But I think it illustrates very well, and it's one of the few that illustrates sort of subdivisions of racial and ethnic mapping. So you will see, and you're familiar since you're at SUNY Downstate, that there is a concentration of the dark red, which are the Afro-Caribbean, and within a larger sort of pinkish red of African American. And this pattern actually repeats itself also in Queens. This is Jamaica, among others, and then also in the North Bronx. But here we are in Brooklyn. And I worked in public health for many years, and these maps are sort of continue to repeat themselves, that Central Brooklyn, Flatbush, et cetera, have a higher diabetes prevalence, higher rates of poverty, higher rates of asthma, sort of the epicenters of poor, just bad public health, right? We have really failed much of the city and in multiple ways. So no matter how you look at it, whether you look at this map, which I think is from 2002, 2004, so it's quite dated, or you look at this, which is 2007, you'll see that the sort of the underlying color, I don't know why they chose this color scheme. It's pretty horrid, but here we are. The darker, I don't even know what to call it, but like soil colored, and then the bubbles illustrate the overlay of diabetes and obesity. So the underlying pattern is diabetes and the bubbles are obesity. So the bigger the bubble, the higher the rates of obesity, and the darker the underlying map structure, the higher rates of diabetes. So again, you can see the areas that are of interest to us are affected by both high rates of obesity and diabetes. But I'd like to disaggregate that and sort of begin to talk a little more about the differences rather than the sameness if we group people together. So in the United States, about 50% of the population, or almost 50% of the population, the Black population, experiences obesity. But in New York City, we're seeing a different picture, which we typically do in terms of health. New Yorkers are generally healthier than the rest of the country, which is a good thing. But there's also this heterogeneity within obesity rates, so that Africans, only about 21% experience obesity. Among Black Caribbeans, it's about 29%. And then in the US born Blacks, it's about 36%. So, so that's why we need to disaggregate and not just look at spatial differences. Because when you put things on a map, it's as if there is a spatial determinant. And there might be, but there might also not be. It might simply that we're obscuring differences by looking at space. If we look at diabetes, though, we see a different non-pattern, right? So in the US, about 13% of the Black population has diabetes. In New York City, Africans, it's about 13%. Caribbeans is about 14%. And in the US born Black population is about 13%. So you'll see that that's the same, right? Essentially no difference. So how do we sort of put that together? So we're looking at in the Black population in New York City that there's a significant difference in obesity prevalence, but there's no difference in diabetes prevalence. So this narrative of obesity rates driving diabetes just doesn't fit here. And so, so that was really the beginning, looking at this data and saying, this is strange. What is going on? And so the first study I'm going to talk to you about is was conducted specifically to compare sort of in the aggregate those who are born in the US and those who are born outside the US, to begin to get an idea of whether this the nativity question, which is used much in immigrant research, whether that explained part of the story. So the objective was to investigate how obesity and diabetes may differ between the foreign-born Blacks and the US-born Blacks living in New York City. And so we used this very large data set called Community Health Survey, which is an annual sample of about 8,500 people. And you can stack the data because there's no, it's a stratified random sample per year. So you can get a total sample of almost 45,000 people. And that's a pretty robust data set. It's cross-sectional, so we don't have any temporal data. We only know at that point in time what is happening in the population. It's also a telephone survey, so everything is self-report, but it's actually pretty reliable data. And so when we took that data, we looked at the foreign-born Blacks, so that included people born in sub-Saharan Africa, in the Caribbean, also people who are born in Canada, the UK, and South America. So this was a very diverse foreign-born Black population, but as with all investigation, you want to start sort of from the top, and then you want to tease out sort of the subdivisions. But what we very quickly saw, and here you have a graph of diabetes prevalence by BMI, was that, and you'll see on the x-axis, we have the BMI categories, so the usuals, underweight, normal weight, overweight, and obesity. And then on the y-axis, we have percent diabetes. And so we see this expected pattern, right? As BMI goes up, we expect diabetes to go up because they correlate. And that is also what we saw, but what became really apparent was that the foreign-born Blacks in the this burgundy color, I think it is, experience higher prevalence of diabetes at all levels of BMI. So even in the normal group, we had almost twice the prevalence of diabetes in the foreign-born Black population than we had in the US-born or the total population. And interestingly, the US-born Black looks exactly like the total population. So the light blue is the total population and the darker blue is the US-born Black population. So that means that if you aggregate the white New York City population, the Asian, the Hispanic, and the Black, US-born Black population, they actually have very similar trend when it comes to BMI and diabetes, whereas the foreign-born population actually does not. So that meant when we then did, I should say that the previous slides were unadjusted analyses, but then we adjusted for age, gender, poverty, education, marital status, children in the home, and for diabetes, we also adjusted for BMI. And so we've found that when we compared the odds of diabetes and obesity, that the foreign-born Blacks had lower odds of obesity, so they were less likely to experience obesity, holding all of the variables, the other variables constant, and they had higher odds of diabetes, again holding these variables constant. So that means that age, sex, poverty, education, marital status, and family situation, and for diabetes BMI did not explain the differences in obesity and diabetes. So we're back to this, and so the trend that we see here was actually, even an adjusted analysis, it actually holds. So, so these differences are not explained by income or age or sex. They're explained by each other, maybe. So then we wanted to take a look at, okay, so the people who come from abroad, who get enveloped into the African American or Black population once they enter the US healthcare systems, are they really the same? Are they similar, but different from African Americans? So we did a second study where we looked at how obesity and diabetes was different between sub-Saharan African immigrants and Black Caribbeans immigrants living in New York City. And then we also wanted to make sure that a variable that we didn't use in the first study because we couldn't, but whether the time living in the United States made a difference in the risk of diabetes or obesity. So we used the same data set, but we subset it and we extracted the African-born Blacks and the Caribbean-born Blacks. And this is really one of the largest data sets available in the United States with a representative sample of both these populations. And so we, just to give you an idea, when we look at the African region, we only chose from the sub-Saharan African region, and the main sending countries are Ghana and Nigeria. And then in the Caribbean region, we took the entire Caribbean basin, and the major sending nations are Guyana, Haiti, Jamaica, and Trinidad and Tobago. And so when we looked at those two populations, 380 from Africa and 2689 from the Caribbean, we found that their mean BMI was, although statistically significantly different, it was not really clinically meaningfully different. But then when we looked at the weight distribution, we saw that the distribution was distinctly different, right? So on the left, you have African immigrants, and then the right, you have Caribbean immigrants. And so we see that the African immigrants were far more likely to be overweight, whereas the Caribbean immigrants were almost equally likely to be in either of the weight categories. So is in essence, the reason why their mean BMI is largely the same is that the distribution is a sort of a shorter, narrower distribution in the African and a more broad distribution in the Caribbean. And so you'll see that we have these stark differences in obesity prevalence, 18 versus 31. And that illustrates itself in both obesity and diabetes prevalence. They are distinctly different and they're statistically significantly different, 18 versus 31. And then in diabetes, we have 8 versus 15. So the Caribbean population in this data set is almost twice, has twice the rate of diabetes compared to the Africans. So again, there's this distinct heterogeneity even in the foreign-born population, even when you bring it down to just 2 regions of origin. And so when we did the odds, again, adjusting for age, gender, poverty level, education, marital status, children in the home, and BMI for diabetes, again, we see that the odds of obesity, so Africans are far less likely to experience obesity compared to the Caribbean. They have about 60% the risk or odds of obesity compared to the Caribbean. But in diabetes, the odds were not different, and that's most likely, even though it sort of trends towards being lower in the African sample, this is probably a matter of sample size and the number of people with diabetes in the 2 samples. So then we also looked at obesity and diabetes by origin and sex, because full disclosure, There's also distinct differences between men and women, and particularly in immigrant populations. So we looked at, here you see obesity on the left, you see African women and African men. And then on the right, you see Caribbean women and Caribbean men. And the comparison, you'll see that the women are far more likely to experience obesity compared to the men. But then, and if we look at the odds, both groups in the women are more than twice as likely to experience obesity. But then if we look at diabetes, you will see a completely different pattern. So African women, despite experiencing relatively high rates of obesity, have very low rates of diabetes. And African men have lower, but not as low rates of diabetes. And then in the Caribbean sample, it is the same, largely the same between men and women. So when we have these differences in high rates of obesity, but similar rates of diabetes between the sexes in the two groups, we have some, you can see how we cannot generalize simply by BMI and draw conclusions about diabetes risk. So again, because of sample size, we most likely don't have statistically significant results. So the confidence intervals, as you can see here, exceeds or includes 1. And so the odds are not statistically significantly different, but there is reason to believe that this trend, based on other evidence, is probably aligned with the actual situation, that African women tend to have lower odds of diabetes despite having much higher BMI. And then in the Caribbean sample, there's largely no difference in the odds of diabetes. So then we also wanted to take a look at whether this duration of residence, so the time people have lived in the United States, which in Mexican populations and in Asian populations has been shown to actually correlate with the risk of obesity and diabetes independent of age. But in these two populations, so African immigrants and Afro-Caribbean immigrants, duration of residence was not associated with the odds of either in either group. So what does this mean? Well, it essentially means that BMI is not a reliable predictor of diabetes risk, and particularly not in the way that we have been taught to think of BMI as a risk predictor. It also shows that Africans have lower prevalence of both obesity and diabetes, and hence, when we look at Africans, Afro-Caribbeans, and African Americans as one, we are obscuring both the high prevalence of obesity and the low prevalence of obesity. And the same thing applies for diabetes. So those trends that you saw in the first slides actually are robust and maintain even after controlling for social demographics. We also know that women have more than double the obesity prevalence than men in both groups, but they don't experience the double risk of diabetes. In fact, their diabetes odds appear to be lower than in men. And then duration of residence, the time living in the United States, and those changes that have historically been associated with living in the United States are not significant in these two groups. And that tends to be something that is happening also in other immigrant groups, so that change that was historically seen is not seen anymore. And I'll talk more about that when I talk about diet. And then a third research area that I'm really interested in relates to clinical and biochemical diagnostics. And so when I was, after I finished my doctoral degree, I had an extraordinary opportunity to do a postdoc at the National Institutes of Health. And I worked with a researcher who has dedicated her life to, and this may sound familiar, uncover heterogeneities in cardiometabolic health among populations of African descent. And that is actually how I met her. I'd met her at a conference. She'd given a talk about the higher risk of diabetes in African men. And I went up to her and I said, how do we explain that? We were seeing the same in this data from New York City. And she said, read everything I wrote and then get back to me. And so I got back to her, and the rest is history. So this team works specifically to document both the phenotypes, but also the risk criteria of previously undiagnosed diabetes in Africans. And these are African immigrants that live in the Washington, D.C. area. And she has demonstrated in this study that hemoglobin A1C actually performs very poorly, specifically in African populations. And she's validated studies from sub-Saharan Africa that have found the same. And so we did a study while I was there that looked at whether this was due to, and you may be familiar with these confounders or these variables that can interfere with A1C performance, such as hemoglobin variants or hemoglobinopathies, so hemoglobin S, C, and or anemias or other nutritional deficiencies. But we actually demonstrated that A1C underperforms even in the presence of those variables. Even in the absence of those variables. So, when I came back to Brooklyn College, I recruited a couple of students to work with me to sort of build an argument for doing either a population study or a clinical protocol that looked at this in a multi-ethnic Black population. And so, and now the two of them are at SUNY Downstate first year medical school. So that's pretty exciting. But we wanted to look at the evidence first, what's in the literature. And so we did a scoping review of evidence that documented hemoglobin A1C performance in African Americans, Afro-Caribbeans, and Africans in the US. And we wanted to summarize that evidence to demonstrate any variation. We knew, we had an inkling that the literature was going to say what they were going to say about African Americans, but we didn't know what evidence was out there about the other two groups. And then we wanted to identify future areas of research. So we found 12 studies, and I will not go through all of them, but I'll just show you that we found 7 studies that documented the performance of hemoglobin A1C in African Americans. We found 1 study that documented the performance in Afro-Caribbeans, and that was a Haitian American sample and a quite small study. And then we found 4 studies that documented the performance of A1C in African immigrants. And full disclosure, they're all from the same lab where I did my postdoc at the NIH, because it is the only protocol in the United States that looks at this. And so what did we find? Well, we found that the literature demonstrates that hemoglobin A1C underperforms in all 3 groups. So the way it underperforms is that in African Americans tend to have a higher hemoglobin A1C regardless of glycemic status. And so there's a likelihood that, and the greater risk for false positives, so a risk of overdiagnosis of glycemic status in African Americans. And in Afro-Caribbeans and Africans, there's actually a risk of false negatives. So a risk of underdiagnosis of glycemic status is likely. And that's been shown certainly in the sub-Saharan African literature that the hemoglobin A1C performs pretty poorly. And so what are the implications of that? Well, because hemoglobin A1C underperforms as a diabetes test in African descent populations in general, and by the way, in many minority populations in general, because it is a test that originated in a largely European origin population. And so there are, we simply did not, by the time it was rolled out, we didn't have enough evidence that it actually performed well in diagnostics. hemoglobin A1C works really well to track people's glycemic control over time. And that's how I first learned about it when I was in undergrad, that hemoglobin A1C was this new tool that could track people's history. We used to only have fasting glucose or random glucose, and that was not really, as you know, a good measure of how well people were regulated. But the implications really are that we need to find alternate testing. Hemoglobin A1C underperforms for a multitude of reasons. Most of them are not, do not relate to the fact that people are of African descent. It simply underperforms. So we suggest alternate testing, which the literature also does, using the OGTT, fasting glucose, or other glycated proteins. So glycated albumin, fructosamines, although that performs pretty poorly, or other glycation end products, or combinations of these tests. But the lack of evidence characterizing hemoglobin A1C performance in these groups, and particularly Afro-Caribbean groups, is astounding. So we're using a test that we do not actually have evidence about how well it performs to diagnose, to track, and to monitor diabetes risk and diabetes management. So really, we need to do more research, which is what we had thought when we started out doing this project. And we think that New York City is really a unique setting where 32% of the African descent population is Afro-Caribbean and 4% is African, really serves as a potential location for investigating this. So the last piece I want to talk to you about, which is typically where people explain these differences, it's the food, right? So it's what people eat. And so that's probably why people have diabetes. And I don't buy that argument. I really do not buy it at all. It's the food. It's always the food. It's what people eat. It's how much they eat, how often they eat. And you may realize at this point that I like to question generalized statements and sort of rooted truths that people believe are our answers, because we actually know frighteningly little about what people eat. And just like our clinical and our biochemical assessments and diagnostic criteria are based largely on white populations, so are the tools we use to assess dietary practices. And so we don't actually have dietary assessment tools that work really well in, even if we were to say, African Americans, Afro-Caribbeans, and Africans. And so, so we make sweeping generalizations based on questions that do not actually elicit the answers that we need. So and then in addition to that, doctors and dietitians have historically spent very little time asking people what they actually eat, while telling people to eat less rice, bread, pasta, starch, whatever it is that we tell people. So, so a couple of years ago, as part of my dissertation research, I actually conducted a qualitative study asking 3 generations of Jamaican families what they eat, why they eat it, what it means to them, who cooks it, where do they get it, and what's in it. And so we didn't get a good assessment of what people eat, but we got a good idea of how people think about food. And so what did we find? We said, actually, I should say this, we wanted to talk to not Jamaicans as this monolithic block of people, but we talked to young people, we talked to their parents or their parents' generation, and we talked to their grandparents, because we already had an idea that there was a distinct difference between the 3 sort of major generational groups. And then we wanted to understand how traveling to the United States from the Caribbean affected people's food habits, and also how social norms and how socioeconomic status and the movement of people and goods between the United States and the Caribbean affected their diet and potentially their risk of disease. And so what we found was that Jamaicans have, and this is not just unique to Jamaicans, but that's who we asked, they have a reverence towards fresh, organic, and healthy food. But we also noticed that globalization really facilitated an availability and desirability of US foods, and that's a global movement. We also found that acculturation, so these changes of eating American foods, of eating fast food, of eating packaged foods, really commences in the home countries at this point, and no longer is something that begins at the entry of the United States. So historically in immigrant research, we have had we've had this notion that once people crossed the border or came off the plane, they started eating differently. They started eating hamburgers and hot dogs, and it was never that. But people may have changed their eating habits, but that change is no longer as drastic as it was 20, 30, 40 years ago. We also know that dietary behaviors that are aligned with the level of acculturation mean that in the US, and in New York City, particularly in the Jamaican community, eating takeout meals is socially acceptable, and it's considered equivalent to home-cooked meals. We also know that the young generation actually eat more servings of fruits and vegetables than adults. They also eat more fruits and vegetables than we may think, and that goes actually for both youth and adults. And we found this health consciousness in the Jamaican community that was quite surprising, given that most of the narrative is around, well, we eat too much rice, we eat too much starch, we eat too many fatty foods. But there is a knowledge and there is a change in social norms around healthy food and physical activity that is becoming the norm. And so what we found was in acculturation, right? The changes that happen as people interact and interface with another culture actually proceeds beyond what we used to think of as you move to the United States and then you eat more calories, more fat, more sugar, more salt, and more animal protein, to actually moving beyond that to eating healthier foods and making healthier food choices. So what does this mean? Well, all of it. All of the diverse cameos that I showed you. Well, it means that we should make absolutely no assumption based on patient's race or their name or where they say they're from. It means that we should recognize the heterogeneity in BMI. And I didn't even get to talk about waist circumference, but that is another measure that doesn't work. We should recognize the heterogeneity in hemoglobin A1C and in lipid profiles and in differences by sex. We should also think about phenotypic differences rather than BMI alone. And then one point that I didn't talk about, but we have to think of when we work with populations that may not have a complete medical family history, right? It's supposed to be the other way around. Family medical history. That if you have people who don't know whether their parents had diabetes, you cannot use that as a variable or as a risk factor. So we actually think that we need to call for region and sex-specific screening guidelines that are not based on European populations, or we just need better tests that have actually been tested in the population where we use them. And then we need to work with and we need to develop culturally competent registered dietitians to take care of the diet and lifestyle recommendations. We have professionals who are trained to actually work with these areas. And so I want to toot the horn for the registered dietitians who are trained to talk diet, to understand culturally specific foods and how to tailor those when there's a need for lifestyle change. And then the advocacy right now is to use fasting glucose or random glucose as measures of glycemic status and really refrain from depending on hemoglobin A1C as a diagnostic tool. And then I encourage you to collaborate with us on upcoming research and intervention on these topics. And then What are the implications for public health? Well, the implications are that there are larger and more systemic issues that are leading to increasing rates of type 2 diabetes. And part of that is the globalization of our food system, but also the globalization of our systems in general. We also have to think about the fact that in our screening criteria in the medical setting do not capture experiences of stress, trauma, or racism, whether it's global or it's in the United States. We also have to think about an opportunity of how do we build in these emerging social norms changes that are also part of this global acculturation that healthy food and physical activity are becoming desirable. And then how do we shift to the population health level of thinking, what if we could prevent diabetes altogether? What if we could make it easy for Brooklyn to make the healthier choices rather than making it small individual steps? And so how could we create environments that prevent type 2 diabetes rather than trying to fix the problem once it has emerged? And so I encourage you to ask questions and reach out to me to collaborate on upcoming research and intervention on these topics. And I think the plant-based idea might not be such a bad one. We would be interested in talking to about that. And I just want to thank all the people who have been part of this work so far. And particularly, I want to highlight my student researchers, 2 of whom are already at SUNY Downstate and 1 who's going in a year and a half. And then, of course, the Jamaican community in Brooklyn for speaking with us. So thank you, and I'd be happy to take any questions.
Thank you so much for speaking with us.
You're welcome. I know that was rapid fire.
Yeah, there was a lot of information there. I was just wondering whether, so there are different levels of A1C at which people, different groups of people are qualified as or identified as having diabetes. Do you think that this difference in level at which they're becoming diabetic, does that extrapolate into like life expectancy in any way, or like longer term effects of diabetes? Does that make sense? Does my question make sense?
Right, so you're saying, okay, so people may not, right, so it's not that people develop or have diabetes at different levels of hemoglobin A1C. It's that hemoglobin A1C is, for some groups, it's like a 50-50. If you compare it to the oral glucose tolerance test, you may misclassify half of the patients with the current cutoff. So it's not even that the cutoff is wrong, it's that you might have, and I didn't bring that data, but you might have, say, a mean hemoglobin A1C in the, let's say, the Caribbean population with diabetes, that's like 6.7. So that's a normal hemoglobin A1C, but that's the mean among the people with diabetes, and they're not well managed. So it means that it just performs poorly. So your question is, does that translate to shorter life expectancy? The fact that we aren't able to identify people with diabetes early enough means that we typically don't identify them until they have complications. So they may show up with neuropathy or disturbed vision, or more severe, they may show up with poorly functioning kidneys, and then they're diagnosed with diabetes. And so people may not be diagnosed early enough. That's the challenge. And then obviously the cardiovascular effects of having poorly controlled type 2 diabetes for a long period of time without treatment or any intervention has long-term consequences. So the short answer is yes. the poor performance of hemoglobin A1C will result in delayed diagnosis in two groups. In African Americans, it may actually result in overdiagnosis. So the risk of overtreatment and the risk of hypoglycemia in people who are not actually yet in the diabetic range. Does that make sense? So if you treat people as if they have diabetes, but they don't actually have diabetes yet, but you've only justified it by the hemoglobin A1C level, you may see higher rates of hypoglycemia.
Okay, that also kind of made me think about, so whether kind of based on the way that our healthcare system is structured, perhaps immigrants don't have as easy access to healthcare, or whether they're just not as familiar with the healthcare system, so they're more reluctant to seek help. And so whether that might have something to do with people presenting at the point at which in their disease process at which they do, and whether you think that has anything to do with some of the results that you found.
Right. So that's an interesting question. So in the two studies that I showed you are actually, it's likely that a fair number of people in those studies have diabetes, but they're unaware. So about 30% of people living in the United States who have diabetes are unaware because they have yet to be diagnosed. In other regions of the world, that's up to 70%. So in sub-Saharan Africa, the challenge is that the vast majority of people who have diabetes don't know, because they don't necessarily have the screening access, or there's not a tradition of being screened. In the United States, at least, we have sort of a tradition of being screened. And you'd be surprised, although there is a lack of access to healthcare, one of the two, both in the African and the Afro-Caribbean community, what's highly valued is access to good healthcare. So people actually access healthcare. And so the data that I showed you is for people who already know that they have diabetes. So we don't have anybody who is misclassified in that category, but we may have an underlying population that we don't even know about. And that's what would be really interesting to see. If we could do like oral glucose tolerance tests and fasting glucose on people as a screening tool, that we might be able to get a completely different picture of what's happening.
Got it. Thank you.
Sure.
Hi, thank you for speaking with us. I just had a question. I'm not sure if I missed it, but listening to you were talking about the hemoglobin A1C levels in relation to Afro-Caribbeans and African Americans. What was the relation to using the hemoglobin A1C to US-born Blacks?
So it tends to overdiagnose. So it tends to be higher than it does in white populations, for instance. So if you compare it to the oral glucose tolerance test, and you have a very good idea of people's glycemic status, both at baseline at 1 and 2 hours, and then compare that with the hemoglobin A1C value, the hemoglobin A1C tends to be higher. So people may be misclassified by their HbA1c as diabetic, but they may be pre-diabetic based on the OGTT. Or they may be normal and by OGTT, but they're classified as pre-diabetes by the A1C. So there's sort of a direct relationship. As it increases, that A1C just increases as well, but it's generally higher.
This is quite interesting because this is my first time hearing something like this. So thank you for your research. Is it something that is known, or how do we get this knowledge into the hands of our practitioners, our medical providers?
Right. So it takes a lot to build an argument for for making changes to guidelines, right? So yeah, how do we do that? We were going to do our research study where we were actually going to reach out to physicians who see people of African descent in Brooklyn or in New York City in general, to ask them how much they know about this, right? Both the underperformance and the overperformance. So the overperformance, so we don't know. We don't know what physicians are saying or how much they know about this or how much they may be interpreting blood tests differently depending on who the patient is. So I don't know. I know how difficult it was to get like the different BMI cutoffs for Asian populations for diabetes risk. So there's a different set of cutoffs of risk for BMI that's lower. It's 23 or 23 and a half for Asians in terms of diabetes risk. And that took, I don't know, it took all of Asia to mobilize to advocate to the World Health Organization and the International Diabetes Federation to advocate for bringing it down, because it was, they could see in epi studies that risk increased at a lower BMI. So it really is with evidence. And so that's why we're, the team at the NIH is working very diligently on getting this on the radar of the World Health Organization and for the International Diabetes Federation to get another directive for sub-Saharan Africa to prevent this delay in diagnosis, which already is happening, but with a faulty test on top of people never getting tested, that just compounds the lack of diagnosis. And then people show up with gangrenous limbs and end up being diagnosed with diabetes at the time where they have an amputation rather than identifying them earlier. So work with us. If we could get a study together to look at hemoglobin A1C levels in people, either using electronic health records, that we could do like a passive assessment of the data and look at people's history of hemoglobin A1C, and maybe if we have measures of, like if we have fasting glucose measures in the history, and then look at the people who progress to diabetes diagnosed with like an OGTT. But electronic health records data is pretty inconsistent. There's a lot of missing data, so it's really difficult to get it together. And people are not necessarily receiving care over their lifespan in the same medical system. So I think we have no choice but to do like a clinical protocol, enroll people at the age of 30 and then track them and see. But the knowledge about hemoglobin A1C in African Americans is it's there. People know. There's just not been strong enough advocacy for it to be reconsidered. But who knows? There's lots of things happening. So we just keep pushing in that direction to reevaluate. The same thing, waist circumference cutoffs for a risk are still based on a Scottish population in, I want to say in the 1960s. And that's used globally, except for Asia. So we don't have enough evidence, they say, yet to change it. So when I talk about some of this, the systemic issues, these are all examples of setting a standard that's based on one population and a Eurocentric lens, and then saying, well, this is the golden ruler. We know this works. Well, we don't know actually that it works. It sort of works, but not equally well in everyone. Any other questions? Oh, I see chat questions.